Assalamu alaikum, everyone. My name is Mustafa. I am a second year medical student, and today I'm happy to be giving this power session. We are going to be going through a couple of anatomy practice questions on ERP. Hopefully, this session helps you guys. I tried to collect questions on topics that were emphasized by your professors. And as you guys probably know by now, anatomy is mainly memorization. A good way to reinforce the knowledge that you have memorized is by doing a bunch of questions. So if I were to give you one advice on how to study for anatomy, I would say do a lot of questions because it would help kind of reinforce that knowledge and actually help you for the final too. And if you don't do your questions, you might end up like this guy right here. He looks really sad. I don't know why he is sad, but if you don't want to look like him on the day of the exam, make sure you do your questions, your anatomy questions precisely. Now, if you have any questions after this session, here are my contact details, my email, and my number. Feel free to ask me any questions after the session. And I would like the session to be as interactive as possible. So if you guys would like to unmute yourselves or text to answer the chat, I don't mind. Let's get started. So I got questions from every single lecture and divided them accordingly. Now let's start with the pelvic floor first. A 59-year-old man undergoes radical prostatectomy for prostate cancer. During surgery, the pudendal nerve is injured. Post-operatively, he develops fecal incontinence. Injury to which of the following muscles is most likely responsible? What do you guys think? So the answer is D, the puborectalis. Now, this question has two different parts. The pudendal nerve is injured. That is the first part of the question. So immediately we can cancel out any question or any of the choices that are innervated by the pudendal nerve. So in this case, the obturator internus and the piriformis are not innervated by the pudendal nerve. So we can immediately cancel them out. The pubococcygis and the puborectalis are innervated by the pudendal nerve. The next part of the question is that he develops fecal incontinence. The muscle that is more involved in fecal incontinence out of these two, choices C and D, is the puborectalis. Now, this picture basically shows the muscles of the pelvic floor. The puborectalis is part of a group of muscles known as the levator ani, and they consist of three muscles: the puborectalis, coccygeus, the iliococcygeus, and the pubococcygis. The puborectalis has a couple of fibers that actually loop around the rectum, forming an anorectal angle. Now, the anorectal angle is important because when the puborectalis muscle relaxes, it allows for this angle to kind of straighten up and then allowing for stool to pass through whenever you want to, if I could defecate or like poo. And the pubococcygis is actually more involved in supporting the pelvic floor and it's not that involved in fecal continence. So that's why the answer would be the puborectalis in this case. Now let's move on. The next question. A surgeon is performing a procedure near the greater sciatic foramen and accidentally damages a ligament, causing instability of the sacroiliac joint. Which of the following structures was most likely injured? What do you guys think? So the answer is A, the sacrospinous ligament. Now, you guys should probably have this picture memorized in your brain right now because probably from all the labs you've attended. The great sciatic foramen is the space right here. It is formed mainly by the sacrospinous ligament, which is a ligament that is attached to the sacrum and the ischial spine. There is another ligament called the sacrotuberous ligament, which binds to the sacrum and the ischial tuberosity. This ligament forms the lesser sciatic foramen. These two foramens have important structures that go through them, but the most important structure is the pudendal nerve. Now, the pudendal nerve exits out of the pelvis through the greater sciatic foramen, and then it loops around and then re-enters the pelvis through the lesser sciatic foramen. So that is an important thing to remember. And all these structures in the picture are also important to remember. So please try to memorize them any way you can. Now let's move on. Which of the following is not a direct function of the pelvic floor? What do you guys think? The answer is C, actively rotating the femur laterally during gait. So out of these four choices, I think C is the one that stands out the most, or the odd one out of the four. You could use this acronym to memorize the functions of the pelvic floor muscles. S stands for support, so it supports the abdominal pelvic viscera. U stands for urinary continence or fecal incontinence, or continence, not incontinence. And R stands for resistance. So whenever you're coughing or lifting heavy objects, the pelvic floor is responsible for resisting any of these pressures. Just an easy question. And let's move on. So now for the questions regarding the pituitary gland. This lecture, in terms of the anatomy, was pretty short, but I tried to collect questions that were emphasized on by Dr. Yaqeen. Now, the first question. A woman has heavy postpartum bleeding. Weeks later, she feels cold, tired, and is unable to breastfeed. Imaging shows an atrophied anterior pituitary with poor blood supply. Which vessel is most likely damaged? What do you guys think? So the answer is B, the superior hypophyseal artery. Now, this slide is really important. It was in Dr. Yaqeen's lecture, and he said that the pituitary gland's blood supply is very unique, and I do agree with him. And he said that a lot of questions might come from it too. So let's try to break it down in a simple way. So the superior hypophyseal artery is responsible for supplying the anterior lobe of the pituitary gland. Before it supplies it, it actually gives off to a plexus known as the primary plexus right here. This plexus is responsible for getting hypothalamic hormones from the hypothalamus, mainly the releasing hormones, and taking them towards the anterior pituitary to stimulate their release of their hormones, and it then goes into the circulation. These two plexuses, or the primary and the secondary plexuses, are connected by this long portal vein. And there are also these short portal veins which connect the pituitary gland to the hypothalamus also. And it's important for negative feedback. It tells the hypothalamus when it's secreting too many hormones and tries to, calm it down or tell it, hey, stop secreting it. And the posterior pituitary is supplied by its own artery called the inferior hypophyseal artery. And it forms its own plexus. That's it for the blood supply. I think I covered everything. And let's move on. A 45-year-old man reports that he has accidentally scraped parked cars whilst driving, often from the side, and feels that his peripheral vision is worsening. An MRI reveals a cellular mass expanding superiorly. Which of the following structures is most likely being compressed? What do you guys think? The answer is C, the optic chiasm. Now, the optic chiasm is the structure right here. It lies on top of the pituitary gland. And in cases of a pituitary tumor, it could lead to compression of this optic chiasm. Now, in the question, it said that there is a cellular mass expanding superiorly. A cellular mass is probably a pituitary tumor because it lies in the cella tunica and it expands superiorly. As we can see here, the optic chiasm is actually on top of the pituitary gland. So a tumor that expands superiorly would most likely affect it. This condition is known as a bitemporal hemianopia, and it's basically when both outer halves of your visual field are lost. This is due to compression of the optic chiasm. And the reason for this is because your peripheral vision or your temporal vision that comes from the side, let's say you see a car from the side, this light is going to be reflected to the opposite side of the back of the eye, okay? Like right here, for both sides. And then once it enters, it's going to cross or decussate at the optic chiasm. Once it crosses, it will then go to the opposite cerebral hemisphere or the opposite side of the brain and go into whatever. You guys don't need to know what happens after that. And the same thing from the other side. Now, the visual field or the nasal visual field, let's say you see something that's in front of you, it will reflect to the outer or the opposite part of the eye, of the back of the eye, and it will stay on the same side. So it will not cross at the optic chiasm. So if there was a pituitary tumor and the optic chiasm was to be compressed, this vision wouldn't be affected. The only vision that would be affected is your peripheral vision or your temporal vision. And that is what happens in a bitemporal hemianopia. In the question, he did say that he crashed cars on his side. This is due to probably because he couldn't see them properly. And this is a very common question that's asked, so please remember it. It's asked most of the time, and it was asked last year for us too. Let's move on. The anterior pituitary developed embryologically from which of the following? What do you guys think? So this question's pretty easy. The answer is the rectus part. It's just a pure recall question. The anterior pituitary gland is formed by the oral ectoderm, whilst the posterior pituitary gland is formed by the diencephalon, which is part of the brain. And that's why we call it the neurohypophysis. So this is just like a pure recall question, nothing, to think about too much. But let's move on. Now for the third lecture, thyroid and the parathyroid gland. A surgeon is performing an emergency tracheotomy and causes significant bleeding around the second and the third tracheal rings. Which structure is most likely to have been injured? What do you guys think? The answer is C, the pyramidal lobe of the thymus, the pyramidal lobe of the thyroid isthmus. Now, the the pyramidal lobe is a lobe that is abnormal. It's only present in a certain amount of individuals, and it arises from the isthmus. The isthmus is the central part of the thyroid gland, and it connects both lateral lobes, the right and the left. And when this pyramidal lobe arises from the isthmus, it forms around the second and the third tracheal rings. Dr. Yaqeen mentioned that in cases of an emergency tracheotomy, it is usually done between the second and the third tracheal rings at a location known as the cricothyroid membrane. Now, when it is done and a person has a pyramidal lobe, due to its being very vascular, it could lead to it, bleeding a bunch when it's damaged, which was mentioned in the question. Now, it's common or it's understandable that you guys would mistake it or choose methylene A or B because they're arteries, right? And they would lead to a bunch of bleeding. But the superior thyroid artery supplies the upper lobe of the thyroid gland, or this lobe right here, whilst the inferior thyroid artery supplies the lower pole of the thyroid gland. And they are present at different levels. The superior thyroid artery supplies the upper lobe at around the first tracheal ring, whilst the lower lobe, which is supplied by the inferior thyroid artery, it supplies it around the sixth tracheal ring. So they wouldn't necessarily get damaged if there was significant bleeding around this area or in an emergency tracheotomy. Now, the internal jugular vein, we will talk about it in a question after, but it isn't present in this area either. Yeah, that's that question. Let's move on. A patient underwent a thyroidectomy. During the procedure, the superior thyroid artery was ligated. Post-operatively, the patient exhibits difficulty modulating voice pitch. Damage to which of the following structures is most likely the cause? So the answer is C, the external branch of the superior laryngeal nerve. Now, this whole picture or image is really important. I'll try to explain it in as simple as I can. So basically, the superior thyroid artery supplies the upper lobe of the thyroid gland, and it runs in close proximity to a nerve. This nerve is called the external laryngeal nerve. Now, in this question, it did say that the superior thyroid artery was ligated. And if it was to be ligated right here on the top at this point, it the external laryngeal nerve is at high risk of also being ligated, which would lead to a lot of symptoms. The main symptom is that the patient would have difficulty modulating his voice pitch. The reason for this is because the external laryngeal nerve is responsible for supplying one muscle, and this muscle is called the cricothyroid muscle. And injury to it would lead to difficulty modulating your voice pitch. Now, that's why if there were to be a ligation of the superior thyroid artery, it should be done closer to the gland in order to prevent damaging the external laryngeal nerve. Okay. Now, for the inferior thyroid artery, which supplies the lower pole of the thyroid gland, it runs in close proximity to another nerve. This nerve is called the recurrent laryngeal nerve. Now, if the ligation is done right here at point two, or in other terms, closer to the thyroid gland, it could lead to damage to this nerve. That's why the ligation of this artery is actually done away from the gland in order to prevent damaging it. So that's why the answer was this. Okay. Now let's move on. Which of the following structures is located posterior lateral to the thyroid gland? Now this is the easy one. The answer is B, the internal jugular vein. Now, this picture or this slide was in Dr. Yaqeen's lecture. As you can see, the common carotid and the internal jugular vein run laterally and kind of behind the thyroid gland, posterior laterally, towards the thyroid gland. It's a pure recall question and doesn't really require thinking. It just helps you orientate the structures around the thyroid gland. Now let's move on. Now for the adrenal gland. Which of the following structures is located anterior to the right adrenal gland? The answer is C. There is also another structure that lies in front of the right adrenal gland alongside the liver. Does anyone know what that structure is? It is the IVC. Now, these two pictures were from your slides. The liver and the IVC are in front of the right adrenal gland, whilst the diaphragm or the right cross of the diaphragm lies behind the right adrenal gland. The same for the left adrenal gland. The diaphragm is present behind it, whilst the pancreas and the stomach is present in front of it or anterior to it. Okay, let's move on. A 103-year-old man is presented with edema of the lower limb and enlarged superficial veins of the abdominal wall. Examination of radiographs and angiograms revealed obstruction of the IVC just proximal to the entrance of the renal vein. This venous blockage may result in dilation of which of the following veins? This is a really long question, but it's easy. The answer is A, the left suprarenal vein. Now, the left suprarenal vein drains into the renal vein because the IVC is closer to the right side. The left suprarenal vein is a really short vein, so it would go into the long vein, which is the renal vein, and then drain into the IVC. Whilst the right adrenal vein, because the IVC is closer to it, it will drain into it directly. Okay. And that's why the answer for this question was the left suprarenal vein. All the right structures drain into the IVC directly, so they won't be affected if the renal vein had an obstruction. Okay. Now, for a quick summary on the blood supply, because it is also important, the suprarenal or the adrenal gland is supplied by three different arteries. It's supplied by the superior suprarenal artery, which comes from the inferior phrenic. We've got the middle suprarenal artery, which is a direct branch of the aorta, and we have the inferior suprarenal artery, which comes from the renal artery. Okay, this is pretty important, and it could be asked in your OSCE, so make sure to remember it. Now, for the next lecture, the reproductive system. I got questions from both the male and the female reproductive system and combined them together. Now let's start. A male gymnast falls from the rings, landing forcibly in a straddle position on the mat. Which portion of the urethra is most likely to be injured in this type of accident? What do you guys think? The answer is C, the bulbar urethra. Now, the bulbar urethra is this part of the urethra right here, and it's highly likely to be damaged in a straddle injury. Now, what is a straddle injury, you may ask? So, a straddle injury is basically when you get injured, right? Your legs are wide apart and your perineum is exposed to any type of surface, and therefore gets injured. So a good example would be falling into a manhole. Hopefully, you guys don't fall into a manhole. It's very scary. One leg goes into the manhole, whilst the other leg is kind of left behind. So your perineum is kind of exposed to the edge of the manhole, and your bulbar urethra is done. It's finished, and it's highly likely to get injured in a straddle type injury, or in this case, falling on a pole. Okay, your legs are separated. Now, the membranous urethra is also prone to a different type of injury, which is also important to remember. In when a catheter is inserted into the urethra and it's inserted without caution, it could cause the membranous urethra to get injured because it is the most narrow part of the urethra, or it's the narrowest part. Okay, these two types of injuries are very important to know. Dr. Atif did say that he's 99% sure he's going to bring a question from either one or maybe even both. So make sure to remember both of these injuries. If it's a straddle type injury, it's the bulbar urethra that's most likely to get damaged. If it's a catheter injury, then the membranous urethra is most likely to get damaged. Let's move on. A semen analysis reveals a deficiency in fructose. Which of the following structures is most likely affected? What do you guys think? The answer is C, the seminal vesicles. Now, I don't expect you guys to know this whole table. I can't lie, I don't know half of the stuff that's on this table either. But all you need to know is that fructose is produced by the seminal vesicles, or the fructose that is present in the semen is produced by the seminal vesicles. I remember this question came last year for us, and it's important to know. You don't need to know the other contents. The testes produce testosterone; it's in the name, right? And the prostate gland is important for producing nutritional components for the semen and for the sperm. But all you need to know from this table is fructose is produced by the seminal vesicles. Now let's move on. BPH, or benign prostatic hyperplasia, is a common enlargement of the prostate. Among the different prostate zones, which zone is most commonly responsible for the enlargement that causes typical BPH symptoms? Now the answer is A, the transitional zone. And for cancer, it would be the peripheral zone. That would be enlarged. Okay. Now, these are the different zones of the prostate gland. You've got the transitional zone, which surrounds the urethra, and that is most commonly enlarged in BPH. We've got the central zone right here, which is not of clinical significance, but it does surround the ejaculatory duct. And we've got the peripheral zone, which is right here, which is most commonly enlarged or where cancer usually arises from, prostatic cancer. And the peripheral, what helps me remember that the peripheral zone is the most common place where cancer would arise from is because it takes up majority of the whole prostate out of all the zones. So where there is more tissue, there's a higher likelihood of cancer arising from it. Okay. And it also surrounds the urethra too. These zones are also important to remember. I know you guys took them in renal, but they could ask you on it in the report too. Let's move on. A 25-year-old woman is undergoing a gynecological examination. The physician notes that her uterus is in the typical position. Which of the following best describes the normal position of the uterus? What do you guys think? The answer is D, anteverted and anteflexed. So this is the normal position of the uterus. It lies on top of the bladder. The first term that describes its position is the anteversion, sorry. Now, the anteversion is referring to the angle of the uterus or the first part of the uterus in contrary to the vagina right here. And it produces this angle because it lies on this part of the bladder. Now, the anti-flex position is referring to this angle right here, which is between the later two-thirds of the uterus and the first one-third of the uterus, which is the anti-flex position. Now, this is the normal position of the uterus. If it is not in this position, it could lead to a lot of different problems. It could lead to, fertility problems, miscarriages, or even, impinging on the rectum. So it's important that it is in this position. Okay? Make sure to remember these positions because they could ask you on it too. Let's move on. During a hysterectomy, which structure is at greatest risk of injury when ligating the uterine artery? The answer is B, the ureter. And which ligament does it run through? I'll explain it on this slide right here. Now, water under the bridge is a common sentence a lot of your professors say, or what they did say for us last year too. Now, the water being the ureter and the bridge being the uterine artery. The uterine artery actually runs through an important ligament that you guys should know. It's called the cardinal ligament or the transverse cervical ligament. This ligament is usually cut in order to get access to the uterine artery and ligate it. Now, when the uterine artery is ligated, the ureter is at very high risk of also being damaged or being ligated too. So caution should be taken. And it's important to know that this analogy really helped me, compare or remember the proximity of these two structures. So please remember them, okay? Let's move on. An anesthesiologist is planning to administer pain relief to a woman in labor to effectively manage pain during the first stage of labor. At which spinal cord levels should the anesthetic be targeted? The answer is C, T11, T12. Now, the reason why it's T11, T12 is because these two segments supply the uterus, okay? Supply the lower part of the uterus. And in the first stage of labor, which is mentioned in this question, it the uterine contractions usually happen. So the uterus is trying to push or eject the baby into the vagina or the cervix. So anesthesia, in order to prevent any pain in the first stage of labor, it has to reach these two segments, okay? T11 and T12. In the second stage of labor, when the uterus reaches the cervix or the vagina, the baby or the anesthesia, sorry, should reach the segments S2 to S4, which are written right now, okay? You should reach S2, S3, S4 in order to prevent any pain in the second stage of labor. Whilst the first stage of labor, T11 and T12 should be reached by the anesthetic, okay? And it could be applied by a couple of different methods, like the epidural method. A couple other methods were mentioned in your lecture, so make sure to remember them too, okay? And yeah, that's about it for the reproductive lecture. Now let's get on to the perineum. Which structure forms the anatomical boundary between the urogenital and the anal triangle? So the answer is C, a line connecting the ischial tuberosities. So I'm sorry for this picture right here. It's hard to my eyes, it's a bit blurry too, but it's the only good image I could find. You've got two triangles right here, okay? You've got the urogenital triangle, and we've also got the anal triangle. The urogenital triangle, or what separates these two triangles, is this imaginary line formed by the ischial tuberosities right here. And for the urogenital triangle, its boundaries are the pubic symphysis on the top, and its two sides are formed by the ischiopubic rami, sorry. Whilst the anal triangle is formed by the sacrotuberous ligament on each side and the sacrum on the back, or the coccyx. And these two triangles are also important. Okay, let's move on. In a male patient presenting with a membranous urethral injury after trauma, where would urine extravasation most likely be located? What do you guys think? So the answer is C, the deep perineal pouch. Okay. Now, this question, in simple terms, it might sound a bit scary, okay? Urine extravasation, but it's basically saying which of the following structures is the membranous urethra present in? Because damage to the membranous urethra would lead to urine exiting it and it, extravasating, okay? Now, over this picture basically shows the structures that are present in the deep perineal pouch. We've got the membranous urethra right here. In a male, we've got the bulbourethral glands. We've also got the sphincter urethra. In a female deep perineal pouch or female's deep perineal pouch, there would be an extra muscle called the urethra vaginalis, okay? And they wouldn't have bulbourethral glands. They would have greater vestibular glands, okay? We also have this muscle called the deep transverse perineal muscle, which is right here. And it is also important. And that is about it for the contents of the deep perineal pouch. This is the reference slide. It mentions all the structures that are present in the deep perineal pouch, and I think they're very important. Let's move on. A surgeon is draining an abscess from the ischiorectal fossa. To avoid damaging the pudendal nerve, which wall of the fossa should be avoided during the procedure? What do you guys think? The answer is B, the lateral wall. Now, here we've got the ischiorectal fossa, okay? Or the ischioanal fossa. It's basically these fat-filled cavities, okay? And why are they important? They're important because they support the rectum and they allow it to expand whenever you want to defecate or like poo. It allows for the rectum to expand and accommodates that. It also has two canals that run through its lateral walls. These are the pudendal canals. Another name for them is Alcock's canal, and they are very important, okay? They run alongst the obturator internus, and they have the obturator fascia, which actually goes on top of it. This question was kind of basically asking which wall is it present on, and it's present on the lateral wall. That's all you guys need to know out of these. Okay, that's about it for this question. Now for the last and final lecture, the external genitalia. A woman has an infection with fluid buildup in the pouch of Douglas. The doctor wants to drain it using a needle through the vagina. Where will the needle go on? The answer is C, the posterior fornix. So this picture or image is from his slides. This is the posterior fornix and this is the anterior fornix. The posterior fornix is used to access the pouch of Douglas or the peritoneal cavity. When there is fluid accumulation, either due to inflammation or an infection, or just fluid building up for some type of reason, the this cavity is usually reached by injecting a syringe into the posterior fornix. The other answers being the anterior fornix, it's not in direct contact, as you could see here, with the peritoneal cavity and could lead to damaging the uterus. The urethral opening is a bit absurd, try to insert fluid from the pouch of Douglas via this, and the vaginal interrotus, I think, is pretty irrelevant. So the answer to this question would be the posterior fornix. Okay. Now, a 26-year-old woman presents with a painful lump on the lower part of her right labia majora near the vaginal opening. Examination reveals a swollen, tender mass in the posterior lateral vaginal vestibule. Which of the following is most likely the diagnosis? The answer is C, the Bartholin gland. Okay, Bartholin glances. Sorry, didn't read that properly. So the Bartholin gland is also known as the greater vestibular gland, and it is a gland that is responsible for lubricating the urethra and also the vagina too. It's the same as the bulbourethral glands in males, but it's just the version that version in females. Okay. It's the cyst right here, and it usually becomes an abscess because of an infection, and it could lead to it blocking the vestibule of the vagina. There are also a couple of other conditions mentioned in the lecture. I would say they're also important, so please try to also cover them. A man presents with a congenital concealed penis. Surgical release of a ligament that extends from the linea alba improves appearance and function. Which ligament was released?
D.
The answer is D, the fundiform ligament. Thank you very much. So, the fundiform ligament is this long ligament right here. It looks like a rope and it goes around the body of the penis. The other ligament, which supports the penis or the body of the penis, is the suspensory ligament, and it connects the pubic symphysis to the body of the penis. These two ligaments are present in only females, so it'd only be these two. And the question did mention that the ligament extended from the linea alba. So the answer would be the fundiform ligament, this ligament right here. And that is the end of ERP practice questions part. I hope you guys enjoyed this session. Best of luck to you all. Inshallah, you all do amazing in your final and get the marks that you all deserve and want. Just make sure you do a bunch of questions because there were a couple of concepts that I couldn't bring questions from in order to not make this part too long. But make sure you do a bunch of questions for anatomy. And inshallah, you guys all come out of the exam looking as happy as this guy right here. You know, you look like a very happy man, and hopefully you all are happy. Before you guys leave, I would appreciate if you guys could scan this QR code right here and give us your feedback on how we tutor so we can improve, inshallah. And thank you very much. Bitawfiq,